management of parastomal variceal bleeding with endoscopic ultrasound-guided coiling and human thrombin fibrinogen injection. These are our disclosures. Parastomal varices occur in approximately 5% of patients with a stoma, with an increased incidence in the setting of portal hypertension. TIPS is the most common treatment modality but is not always feasible. EUS-guided coil placement with glue injection has been shown to be an effective alternative treatment option. Recent data shows promising results for the use of thrombin as an alternative to glue. However, there are no data available on its use from U.S. centers. We present 2 cases of EUS-guided treatment of parastomal varices using coils and a combined thrombin fibrinogen product. Nestor coils were used for EUS-guided embolization. They come in the shown sizes and are selected at about 1.25 to 1.5 times the target vessel diameter. In our cases, 10 and 6 mm vessels were treated, with 2 and 3 coils providing a stable scaffold for durable occlusion. First, we'll begin by preparing the needle. The stylet is removed. The needle is flushed with sterile water to clear any air and ensure smooth passage of the coil. Next, we prepare the coil itself. The coil is removed from its holder, and the outer plastic sheath is removed. The inner metal coil sheath is attached securely to the needle using the lower lock. At this point, the coil is carefully loaded into the needle. Using the stylet, we gently advance the coil until it is in the needle, which can be determined by the length of the metallic sheath of the coil. The stylet is then withdrawn and the coil sheath is removed. The stylet is then advanced into the needle. It is important not to advance the stylet all the way in order not to deploy the coil. The stylet is stopped short of the length of the coil sheath. Once the varix is clearly visualized under EUS, the needle is advanced into the varix. The stylet is used again to carefully push the coil forward into the varix, allowing it to unravel within the varix. If additional filling is needed, a second or third coil can be prepared and deployed in the same fashion. Between deployments, the needle is flushed with sterile water to prime it for the next coil. Thrombin fibrinogen is supplied as 2 preloaded 2 ml syringes in a dual syringe system. After coil deployment, the needle is flushed with sterile water and connected to the syringe using a lower lock. The thrombin and fibrinogen components are then injected under direct EUS visualization. Scope stability was somewhat limited by the short insertion distance, but was maintained with the assistance of a second physician throughout coil deployment and thrombin injection. Prophylactic IV antibiotics were administered at the time of the procedure and continued for 5 days. Case 1 is a 40-year-old female who had presented with a second episode of bleeding from her ileostomy bag within the last 2 months. Her medical history included rectal cancer with liver mets for which she had received chemotherapy followed by a low anterior resection and right hepatectomy. An attempted ileostomy reversal was unsuccessful due to the presence of parastomal varices. She had been undergoing palliative chemotherapy. The patient presented with bleeding and a hemoglobin level of 4.9, requiring 5 units of blood transfusion. After a multidisciplinary discussion, she was deemed a poor candidate for TIPS and managed conservatively. 2 weeks later, she experienced another episode of clinically significant bleeding and was planned for EUS-guided therapy. CT scan demonstrates the feeding parastomal vessels. The endoscopic findings revealed a single 10 mm tubular anechoic structure consistent with a feeder vessel. The feeder vessel to the parastomal varices was accessed using a 19-gauge needle. Contrast was injected to confirm the anatomical location of the vessel. Initially, the contrast was observed filling the feeder vessel in retrograde. However, on delayed imaging, the contrast was seen draining through superficial subcutaneous vessels. 2 0.035-inch coils were advanced into the vessel, the first one measuring 14 mm in diameter and 14 cm in length, and the second one measuring 10 mm in diameter and 7 cm in length. The coil size was decided based on 1.25 to 1.5 times the diameter of the vessel. The needle was flushed between each coil deployment, and the needle stylet was used as a pusher. After the coils were densely packed within the vessel, resistance was encountered to further deployment, indicating successful packing. At this point, 4 milliliters of a thrombin fibrinogen mixture was gradually injected into the vessel. This mixture was used to promote clot formation and achieve complete obliteration of venous flow within the vessel. Post-procedure Doppler imaging confirmed that the varix was successfully obliterated with significantly reduced residual flow effectively preventing further variceal bleeding. Case 2 is a 62-year-old female who presented with bleeding through her colostomy. Her past medical history included sigmoid cancer treated with a colostomy and a right hepatectomy for liver mets. She recently experienced a recurrence of her disease and was undergoing palliative chemotherapy. She had a history of similar bleeding episodes secondary to parastomal varices, previously managed with IR embolization and coiling. Her initial hemoglobin was 7.1, requiring 3 units of blood transfusion. Following a local multidisciplinary meeting, she was referred for EUS-guided treatment. CT scan demonstrated parastomal varices. The scope was introduced through the stoma, where a 6 mm feeding vessel was identified. Using power Doppler, splanchnic venous blood flow was confirmed as demonstrated by monophasic flow on power wave Doppler. A 19-gauge needle was used to puncture the vessels. Initial attempt proved challenging as the vessel was in a difficult location due to its superficial nature with surrounding soft tissue and an unstable echoendoscope position, highlighting the importance of stabilization of the echoendoscope during vascular access. Following confirmation of vessel location, 3 coils were sequentially deployed. The coil size was selected 1.25 to 1.5 times the short axis diameter of the varix to ensure adequate coverage and closure. Each coil measured 0.035 inches in size, 8 millimeters in diameter, and 7 centimeters in length. The needle was flush between each coil deployment, and the needle stylet was used as a pusher. Doppler flow was checked throughout the process. After successful coil placement was confirmed by endosonogram and fluoroscopy, the varix was treated with an injection of thrombin and fibrinogen mixture. A total of 4 mL was gradually injected for completion of the treatment. The needle was kept in place for a few seconds and then gently withdrawn after the procedure. Following treatment, minimal flow was observed within the vessel, indicating successful obliteration. In case 1, no further bleeding occurred, and hemoglobin initially improved before later declining, likely from chemotherapy. Follow-up CT imaging showed coils intact, confirming durable hemostasis. Given her advanced metastatic disease, no further procedures were planned, and she passed away 8 months later due to disease progression. In case 2, the patient was readmitted about 2.5 months later with recurrent bleeding. Follow-up CT showed coils intact with residual flow within vessel, indicating incomplete obliteration. She was successfully treated with repeat EUS-guided glue injection, after which hemoglobin remained stable. Due to progression of comorbid conditions, she later transitioned to hospice care. EUS-guided coil embolization combined with thrombin fibrinogen injection provides effective and immediate vessel occlusion while minimizing the risk for rebleeding. It promotes physiologic clotting without the equipment damage or embolization risk seen with glue and has shown good safety in prior studies, though some patients may need repeat treatment. EUS-guided coiling with thrombin and fibrinogen is a safe and minimally invasive option for stomal varices. It offers effective hemostasis and may serve as an alternative to glue or IR-guided therapy, though further studies are needed to define long-term outcomes.